This lecture is about the prosthetic lesions producing regurgitation. Then, regurgitation may be prosthetic, with turbulence behind and originating from inside the sewing ring of the valve, or paravalvular when originating outside of the valve. The main causes for prosthetic regurgitation are leaflet rupture or calcification in a bioprosthesis, impaired closing due to thrombus or pannus, endocarditis, and other. The main causes for paravalvular leaks are disruption of the sewing ring, sutures, and endocarditis. A cause of frequent prosthetic regurgitation in a bioprosthesis is calcification of the leaflet. The leaflet shows these echogenic structures attached not only to the leaflets but also to the struts. They are not mobile, and M-mode shows they are formed by several straight echo lines with perfect smooth borders. Here another view in an apical 4-chamber and a short X. Same characteristic calcification. Another frequent cause is rupture of the leaflets. The diagnosis usually is easy by demonstration of the leaflet moving beyond the plane of the ring. That can be seen in a transthoracic echo, but is much better evident in a transesophageal, when we demonstrate a leaflet tip going behind the ring further into the left atrium and pointing to the atrial cavity. Here there is obvious rupture of one leaflet of this bioprosthesis in mitral position. We see part of the leaflet during diastole coming this way, and during systole going behind the ring into the left atrium. Same patient, the leaflet moves beyond the ring during diastole and the presence of a regurgitation. In this apical view, it's better evident the leaflet moving beyond the ring into LA. There is a severe prosthetic regurgitation, and the turbulence is originating right behind the disc. TEE, same patient. Obvious rupture of this leaflet and a severe regurgitation through the ring and not by paravalvular region. Another example of a ruptured bioprosthesis. TEE makes it very easy to diagnose this case of rupture involving a leaflet. TEE showing a severe paravalvular regurgitation in a bioprosthesis. There is also a prosthetic regurgitation. Let's see these patients with a bioprosthetic mitral valve. In this apical 4-chamber view, the prosthetic seems to be okay. TEE of the same patient shows a mobile structure right here and a certain thickening of the leaflet. This thickening of the leaflet is better demonstrated here with mobile structure. At first view, this may be a thrombus, but we cannot rule out vegetation of endocarditis. The probability is greater for vegetation since there is this filiform structure moving, and not only a possible vegetation in the ventricular side of the valve, but also in the atrial side that may look at a possible abscess. Color Doppler shows the regurgitation to be paravalvular, mild to moderate. This kind of regurgitation is a frequent complication of endocarditis, what adds to the possibility for the differential diagnosis. Obviously, the clinical impression is also very important. Another patient with a bioprosthesis in mitral position, and we notice right away the mobility of this part of the sewing ring close to the aorta, where it should be attached, and hence to have the same displacement. This is not happening. There is a different motility of these regions, what is very suggestive of a paravalvular leak. There is also some thickening of the leaflets, suggestive of endocarditis. Another patient with a double tilting disc. Notice how sometimes it is difficult to differentiate the type of mechanical valves, if one or two discs. However, it's easy to identify if it is malfunctioning or not by Doppler, and if there is malfunctioning. we indicate a transesophageal echo. In this case, we notice what appears to be a paravalvular regurgitation. The apical fourth chamber demonstrates a turbulence coming from outside of the sewing ring. TEE shows the clear detachment of the sewing ring. Another case. Now the region of detachment seems to be here. Look at the difference of movement between the sewing ring and the wall. The apical two chamber shows a paravalvular regurgitation in the inferior as well as in the anterior portion of the sewing ring. Notice that not only there is a paravalvular leak, but also a flow toward the left ventricle during diastole through the region of the dehiscence. Look at this case, a bioprosthesis probable dehiscence, both at the medial and lateral regions of the sewing ring. Both sides are not moving together with the walls. But there is also something here at the leaflet that shows the possibility of vegetation or endocarditis. Intraoperative TEE, in other case. Look at this small paravalvular leak right after implantation, yet at the operating room. We may find these tiny leaks that disappears later on. It is not necessary to return to circulatory bypass to fix this. Another small paravalvular leak. Now, with a paravalvular leak like this, it is severe enough to return to circulatory bypass for fixing. TEE of a mitral bioprosthesis with a clear rupture of one leaflet. A rupture does not have to be caused by endocarditis. This patient, for instance, had no endocarditis. It may be just wear and tear. There is a severe prosthetic regurgitation with Coanda effect. Now, a transesophageal echo showing an example of a paravalvular leak in a mechanical prosthesis. Notice that it appears to have a detachment of the sewing ring at this location. There is a mild prosthetic regurgitation here, coming from within the ring, that may be considered normal. And here, a paravalvular regurgitation. The turbulence is originating from the disc insertion region. Endocarditis in a biological aortic prosthetic valve with ruptured leaflet and an abscess in the posterior aortic wall. Important prosthetic regurgitation. Mitral bioprosthetic valve with pannus and several regurgitation jets. Notice that during diastole, the echo dense trace in the M mode is formed by only one line, different if it were calcium, when it would show several lines, and not a vegetation, where it would have a smudge appearance and the line would have a torn paper aspect. Apical fourth chamber of a bioprosthetic mitral valve with restriction of leaflet motility, with appearance of pannus, produced an important mitral regurgitation. This another patient. For certain, is not a pannus. It has features of a thrombus. See that it is also in the left atrial wall, beyond the sewing ring, and features of endocarditis, including the small paravalvular regurgitation. Help from the clinical status of the patient. This was endocarditis. Double disc mitral prosthesis with dense pannus like tissue entering the sewing ring, moderate regurgitation. TEE of a bioprosthesis mitral valve with a vegetation of endocarditis. Color Doppler shows turbulence of regurgitation in the left atrium that did not seem to be coming from the orifice of the prosthesis. Careful searching depicted this paraprosthetic detachment with Coanda effect and an important paraprosthetic leak.